Welcome to the recent approval episode of the ASCO University Weekly Podcast. My name is Rami Manochakian. I'm a thoracic medical oncologist at Mayo Clinic, Florida. Today, I will discuss the approval of Durvalumab for the treatment of patients with stage 3 non-small cell lung cancers after completion of chemoradiation therapy. As a background for today's discussion, it is noteworthy to mention that over the last few years, the use of immunotherapy drugs, in particular immune checkpoint inhibitors, has been one of the major groundbreaking advances in the treatment of many cancers. One of the main cancers where immunotherapy has made a difference is lung cancer, which is the top leading cause of cancer-related deaths in the United States and worldwide. We currently have 3 checkpoint inhibitors approved for treatment of metastatic non-small cell lung cancer. These are pembrolizumab and nivolumab, both of which are monoclonal antibodies against PD-1, and then atezolizumab, which is a monoclonal antibody against PD-L1. While these drugs have approvals in stage 4 cancers, until very recently, we have had no immunotherapy drug approved for earlier stages of non-small cell lung cancer. When it comes to patients with stage 3 non-small cell lung cancer, which represent about 1/3 of non-small cell lung cancer patients, for many years we have had no changes or advances in the way we manage these patients. Except for very small percentage of patients that undergo resection, standard of care for the majority of these patients is concurrent chemoradiotherapy with median progression-free survival of around 8 months and 5-year survival rate of 15 to 20%. Durvalumab is a selective human IgG1 monoclonal antibody that blocks PD-L1. And it was previously approved in 2017 for patients with locally advanced or metastatic urothelial carcinoma whose disease progressed on chemo. On February 16 of 2018, Durvalumab was FDA approved for the treatment of patients with stage 3 non-small cell lung cancer whose tumors are not able to be surgically removed and whose cancer has not progressed after treatment with chemoradiotherapy. The approval of Durvalumab was based on the Pacific trial, which is a randomized phase 3 trial of 709 patients whose cancer had not progressed after completing concurrent chemoradiation therapy. Patients were randomized in a 2-to-1 ratio to receive Durvalumab at a dose of 10 mg per kilogram or placebo every 2 weeks for up to 12 months. The study drug was administered within 6 weeks of patients' completion of chemoradiation. The 2 co-primary endpoints of the study were progression-free survival and overall survival. Based on a planned interim analysis of the study, with median follow-up of 14.5 months, the median progression-free survival for patient taking Durvalumab was 16.8 months, compared to 5.6 months for patient receiving placebo, with stratified hazard ratio for disease progression or death of 0.52, with a 95% confidence interval of 0.42 to 0.65 with a p-value of less than 0.001. A progression-free survival benefit with Durvalumab was consistently observed across all pre-specified subgroups. And also, a benefit was observed irrespective of PD-L1 expression. Data on overall survival were immature at the time of the interim analysis. Looking at secondary endpoints, 12 months progression-free survival rate was 55.9% for Durvalumab versus 35.3% for placebo. The 18 months progression-free survival rate was 44.2% versus 27% respectively. Another key secondary endpoint was overall response rate, and it was higher with Durvalumab than with placebo, 28.4% versus 16%, along with longer median duration of response for Durvalumab patients. The median time to death or distant metastases was 23.2 months with Durvalumab versus 14.6 months with placebo. Common side effects of Durvalumab included fatigue, cough, dyspnea, pneumonitis or radiation pneumonitis, upper respiratory tract infection, rash, and diarrhea. Grade 3 or 4 adverse events occurred in 29.9% of patients who received Durvalumab and 26.1% of patients who received placebo. Discontinuation due to adverse events occurred in 15.4% of patients in the Durvalumab group and 9.8% of patients in the placebo group, with the most common cause for discontinuation in both groups being radiation pneumonitis. Serious adverse event occurred in 28.6% and 22% respectively. Serious risk of Durvalumab included immune-mediated side effects such as pneumonitis, hepatitis, colitis, nephritis, and others, as well as infections and infusion-related reactions. Death due to adverse events occurred in 4.4% of patients in the Durvalumab group and 5.6% of patients in the placebo group. The approval of Durvalumab as a consolidation therapy in patients with unresectable stage 3 non-small cell lung cancer after completion of concurrent chemoradiation represents, in my opinion, a major breakthrough advancement in managing a population of patients with unmet needs. Although overall survival data are immature, the clinical benefit of the drug was clear and evident, especially through the impressive improvement in progression-free survival of 11 months compared to placebo, along with the fact that a benefit in progression-free survival was observed across all pre-specified subgroups and regardless of PD-L1 expression. In addition, there was an improvement in all secondary endpoints, which are 12 and 18 months progression-free survival rates, response rate, duration of response, time to death or distant metastases. As far as the safety profile of Durvalumab, it was consistent with what we know of the checkpoint inhibitors. Incidence of grade 3 or 4 events was close between the Durvalumab and placebo groups. The incidence of pneumonitis or radiation pneumonitis was noted to be increased in both groups, but that was expected since all these patients received definitive concurrent chemoradiation. Based on all the above, in my opinion, Durvalumab will become or has become the standard of care for patients with unresectable stage 3 non-small cell lung cancer patient after definitive concurrent chemoradiation therapy. Thank you for listening to this week's episode of the ASCO University Weekly Podcast. For more information on immune therapy and the treatment of non-small cell lung cancers, visit the Comprehensive E-Learning Center at university.asco.org.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.